right? Okay, now after the discussion of this cardiac cycle, you have to look at the point where the first heart sound and second heart sound will be created, right? So I'm writing here, my question is, tell me in which phase of cardiac cycle the first heart sound is going to be created, the first heart sound, right, and the second heart sound. Okay, so could you recall this whole picture? That is very important, because now many things will be discussed in this class as well as in the next class which is related to the cardiac cycle. So all these phases should be on your fingertip. If I ask you what is happening, what will happen to the pressure, you have to answer. So if you look at the first heart sound, I told you that is nothing but closure of the atrioventricular valve, and it is written here, closure of the atrioventricular valve. So you can point out that this is happening at the end of diastole, or you can say this is happening at the beginning of isovolemic contraction. So what should be the better answer, end of diastole or end of this last rapid filling phase or beginning of isovolemic contraction? Always remember, if the ventricle is stop contracting at the end of diastole, first heart sound is not going to happen, because I told you earlier that whenever ventricles start contraction, then and then only the blood will try to return back towards the atrium cavity, and that will lead to closure of the tricuspid valves. So onset of contraction will leads to closure of AV valves, right? So I'm writing here, so first heart sound will start at the beginning, okay, at the starts of isovolemic contraction. Similarly, if you look at the second heart sound, see, second heart sound is due to closure of the semilunar valve here. This is the second heart sound point, closure of the semilunar valve. So where it is happening? At the end of protodiastole, but I told you protodiastole, forget about protodiastole. So at the end of systole or beginning of diastole. But again, which you have to answer, beginning of diastole will be your answer, because if the heart is stopping at the end of systole, then the second heart sound is not going to happen. Whenever the ventricle will start relaxation, the chamber relaxation means the blood will try to fall back from pulmonary artery towards the ventricular cavity, and that will leads to closure of the semilunar valve. So I'm writing here that second heart sound will appear, okay, at the starts of isovolemic relaxation phase, right? So first heart sound beginning of isovolemic contraction, second heart sound beginning of isovolemic relaxation. All of you know that there are many other differences between these two heart sound. Second heart sound, you remember like this, that S for second, S for short. Short means it is shorter in duration. The duration of this heart sound is 0.12 second is the duration of this sound, very small duration sound, okay. Then sharp. Sharp means the frequency, the pitch of the sound is very high. Frequency of the sound, you know, the sound wave means there will be an amplitude, there will be an frequency. So sharpness means the frequency is 50 Hz. This is known as the high pitched sound, right? And it is also a soft sound. Soft means the decibel, okay, the decibel or the amplitude of this sound, amplitude of the second heart sound is low, so low amplitude sound, right? So these three things you have to remember about second heart sound. On the other hand, if you look at the first heart sound is just opposite. So it is a longer duration. Longer duration means it is not very huge long than that of the second heart sound. This is only 0.15 second, right? So second heart sound duration is only 0.12 second. It has been asked in MCQ. First heart sound duration is little longer than that of the second heart sound, that is 0.15 second. Then second is it's a low pitched sound, low pitched sound with a frequency of 25 to 45 Hz. So 25 to 45 Hz, it is audible frequency. Yes, obviously it's an audible frequency. So that's why we can easily hear the first and second heart sound. And then it is a loud sound, L-O-U-D. Loud means it is a large amplitude sound, right? So this way you have to remember the difference between this first and second heart sound. Now, if I ask you that is there any correlation of this heart sound with the ECG, means if I want to correlate that in which phase of ECG which heart sound is going to produce, then the concept is like this. Suppose I am drawing a normal ECG, we have discussed in the previous session, right? So this is QRST, okay. So this is my T wave, Right. So look at first heart sound. We are first thinking like this. First heart sound. First heart sound means onset of ventricular systole. You told me earlier that it is the isovolemic contraction. So ventricular contraction has to be started. Ventricular contraction means, first of all, there should be starting of depolarization. Always remember, please don't forget that I told you that if this is your action potential, okay, it correlates with the ECG. Action potential phase 0 means the QRS complex will corroborate with this, right? I told you in the earlier session. Now, calcium enter only during this phase 2. That means first there will be starting of the electrical event, and then only calcium will influx into the cell, and then only the contraction and relaxation will start like this. Getting my point? So this action potential, this black color diagram, look at this action potential is known as the electrical event, and this red color diagram or graph, this is the contraction followed by relaxation, means this is the mechanical event. This is the mechanical event. Mechanical event means this part is the systole and the remaining part is the diastole. So what we are understanding from here, that always the electrical event happen first, and then only the mechanical event is going to happen. This is true for every muscle. First you require action potential. Okay, then only the contraction, the mechanical contraction, the relaxation is going to start, right? So now we all know that first heart sound means ventricular contraction has to be started. So contraction means I require ventricular depolarization. Ventricular depolarization will be started from which wave? That is a Q wave in the ECG. So do you think the Q wave is going to cause full contraction of the ventricle? Answer is no. Q wave is only septal depolarization. So after the Q wave generation, when the R wave is starting, right, then only the ventricle is going to cause full contraction. That means the first heart sound will never appear during this Q wave. It will appear when the R wave is going on, and it is said in the books that the peak of this R wave, this is the point where the first heart sound is going to appear, right? So please note down this important concept. So first heart sound means it is the peak of R wave, right? So similar way, you think of the second heart sound. Second heart sound means this has to happen during the full relaxation. Okay, now you look at here. What is happening? First the electrical relaxation is happening or the mechanical relaxation is happening? First the electrical relaxation, that is the repolarization, has to happen, and then only the ventricular muscle will relax fully. So second heart sound means we all know that will happen during the beginning of relaxation of the ventricle. Relaxation means first electrical relaxation has to be done. Electrical relaxation means this is nothing but repolarization. Repolarization nothing but T wave. So at the end of T wave, I can understand that the second heart sound is going to appear. Getting my point? So the first heart sound corresponds with the peak of the R wave, and second heart sound corresponds with the end of the T wave, right? Now what about third and fourth heart sound, right? Because we know apart from first and second, third and fourth heart sound is also there. So third and fourth heart sound, both of this heart sound occurs due to vibration of the ventricular wall or due to the vibration of the blood which is present in the ventricular cavity. What I am saying? Okay, suppose your ventricle is in a relaxed condition and ventricular filling is going on. If you go back to this cardiac cycle diagram, see, ventricular filling is occurring during this first rapid filling phase also, during this last rapid filling phase also. During diastasis, the ventricular filling is occurring, but that is very slow. If the ventricular filling is slow, then the ventricular wall is not going to vibrate. Ventricular wall vibration means the filling has to be rapid. So there are two rapid phases, first rapid filling phase and last rapid filling phase. So third and fourth heart sound, third heart sound is going to appear during first rapid filling phase of the cardiac cycle, and fourth heart sound is going to happen during last rapid filling phase of cardiac cycle. Why? Because during this two rapid filling phase, what is going to happen? There will be vibration of ventricular wall. there will be vibration of ventricular wall as well as the column of blood which is present in the ventricular chamber, and that vibration will leads to production of sound. Getting my point? Sound means there should be some vibration. First and second heart sound was due to vibration of the valves, but here this is not due to vibration of the valves. This is due to vibration of the ventricular wall as well as the volume of blood which is present in the ventricular chamber. Why there is vibration? Because rapid filling occurring inside the ventricle. Now if I ask you, what will be the duration of both of this sound? If you look at the duration of this first rapid filling phase, last rapid filling phase, then you will be able to answer that both of this phase has same duration, that is 0.1 second is the duration of the third heart sound, 0.1 second is the duration of the fourth heart sound. That means both of this heart sound has the same duration, that is 0.1 second. If I ask you what is the pitch, what is the frequency of these two sound, frequency of both of this heart sound is approximately 10 Hz, approximately 10 Hz. So do you think 10 Hz frequency means are these sounds audible? Answer is no. 10 Hz means we know our audible frequency is from 20 to 20,000, right? So 10 Hz frequency means this is inaudible. That's why we say third and fourth heart sound normally it is not heard over the precordium region. If you put stethoscope on a normal adult person, third and fourth heart sound, they are not audible, right? But there are certain condition where audible third heart sound is seen. When the third heart sound will be audible, when the frequency is increased to approximately 30 Hz, okay, then and then only the third heart sound will be audible. What will be the causes? Causes are hyperdynamic circulation, right? And second is increase blood filling or increase volume of blood in the body. What I'm saying, third heart sound will be audible when the frequency increases from this 10 Hz to 30 Hz approximately. And when this is going to happen, when the blood is flowing inside the cavity of the heart in a higher velocity, that is meaning the hyperdynamic circulation. Blood is running with a high velocity. So during the first rapid filling phase, blood was running towards the ventricular cavity. Now due to huge velocity, the running is increased towards the ventricular cavity. So more faster running of blood towards the ventricular cavity, that will cause more vibration, and that is the meaning of hyperdynamic circulation. What is the example? All of you know that in case of children, because of the heart rate is very, very high, okay, so in case of children, okay, heart rate is very, very high, that will also produce hyperdynamic circulation. In case of anemia, okay, hyperdynamic circulation can be seen. In case of thyrotoxicosis, okay, in case of hyperthyroidism, again hyperdynamic circulation can be seen. So during all these conditions, children, anemic person, okay, hyperthyroidism, you can get the third heart sound. And when the increased blood volume is there, typically this is seen in during congestive cardiac failure patient, the blood volume is very, very high, and that can also leads to audible third heart sound, right? That is the pathology of audible third. Similarly, if I ask you what is the cause of audible fourth heart sound, right? Audible fourth heart sound means again the frequency of this heart sound will be near equal to 30 Hz, right, from 10 Hz, and the cause here is increased stiffness of the left ventricular wall, increase stiffness of ventricular wall, okay, ventricular wall. What I'm saying, ventricular wall, okay, whenever the blood is running towards the ventricular cavity, there is vibration normally, but that vibration frequency is less. But if the ventricular wall becomes stiffer, then this last rapid filling phase will produce more vibration of this stiffer wall, right? If a soft surface and a hard surface, if you give same amount of pressure, which will produce more sound, the hard surface, the same thing is happening on the ventricular wall, right? That's why due to any condition, if there is increased stiffness of the ventricular wall, that can lead to audible fourth heart sound. The typical example is fibrosis of the ventricle after myocardial infarction, post-myocardial pressure, fibrosis of the ventricular wall, or if there is hypertrophy of the ventricular wall, that sometimes also causes increased stiffness of the ventricular wall. In this condition, the audible fourth heart sound you are going to get, right? So at the end, what is the cause of third heart sound? That is occurring during first rapid filling phase. What is the cause of fourth heart sound? That is occurring during last rapid filling phase. We have already understood that last rapid filling phase is due to atrium contraction. So last rapid filling phase is the active filling of ventricle and it is occurring during atrium contraction. So if I ask you, atrium contribution leads to appearance of which heart sound? Your answer is fourth heart sound, because that is corresponding with the last rapid filling phase, right? So now with this concept, if I go back to this ECG diagram, okay, so this is one ECG, I am drawing another ECG here. So again a P wave, again a QRS complex like this, P wave. Fourth heart sound, think of fourth first, then you will go back to the third heart sound. So fourth heart sound is due to atrium contraction, right? Atrium contraction means you require atrium depolarization. Atrium depolarization is denoted by which wave? P wave. So first the depolarization of the atrium will start. At the end of atrium depolarization, atrium will contract and that will leads to fourth heart sound. So this is the point where fourth heart sound is going to be created. So now I can understand, we have find out the point where first heart sound is occurring, second heart sound is occurring and fourth heart sound is occurring. So obviously in between this second and fourth, within this isoelectric line, or you can say TP segment, this is the TP segment or this isoelectric line, this is the point where third heart sound is going to be created, right? So this is the heart sound and ECG correlation, and this is all about the different phases of cardiac cycle that we have discussed. Now our job is not done. Now our job is to discuss the change in pressure during cardiac cycle. Okay, so now we have to discuss that during this cardiac cycle, different phases of cardiac cycle, how the atrium pressure is changing with different phases of cardiac cycle, right? If you look at the atrium pressure change, then you will find out a pressure changing curve like this. So what is this? So this is nothing but typically you are very famous, the jugular venous pulsation, right? So this is the nothing but atrium pressure changes, atrium pressure changes. If you look at the ventricular pressure changes, you are going to get a curve like this, okay? So you are going to get a curve like ventricular pressure changes like this, okay? So sudden rise of ventricular pressure followed by sudden fall of ventricular pressure. So this is ventricular pressure change. And if you look at the aortic pressure change, so we are now looking at the left ventricle. Aortic pressure change will look like this. Okay, so this is nothing but aortic pressure change. So all these three different curves we have to understand for our MCQ purpose. And if you plot all these three curves in a diagram, that diagram is known as Uyghur's diagram. So what I am saying, this is known as Wiggers. Uyghur's. The name of the scientist is Uyghur's. Uyghur's plotted all these three curves along with ECG and other parameter on y-axis in a curve, and the x-axis is time. So when you are plotting all these three curves on y-axis along with other curve also like ECG and other things, and x-axis is time, and you are plotting with respect to cardiac cycle phases, that diagram is known as Uyghur's diagram. Now we are going to discuss this Uyghur's diagram, that is the pressure changes during cardiac cycle, right? So what I require to draw certain line first, okay? So this is first line, okay? So I told you that x-axis of this curve is nothing but time axis, and y-axis of this curve is nothing but the pressure axis, right? So x-axis is time and y-axis is pressure. So what about this line? Okay, so these lines are nothing but the time gap between these first two lines. This is the phase of isovolumic contraction. See, so we are describing the cardiac cycle only, but pressure change in cardiac cycle, different type of pressure change, atrium, ventricular is a pressure, right? So isovolumic contraction. Then next, the time gap between these two, this is the ejection phase of cardiac cycle. this is the ejection phase of cardiac cycle. Ejection phase is nothing but the rapid ejection phase and slow ejection phase, right? So rapid ejection and slow ejection. And then this time gap between these last two lines, this is obviously isovolemic relaxation. We are ignoring the protodiastole phase here because that has no clinical significance, right? So this is isovolemic relaxation, right? Now during these different phases, we want to plot the ventricular pressure. So look at this red color point, this will denote the ventricular pressure. So I am writing here ventricular pressure with red color, right? And I will take another color, suppose this is green color, this is aortic pressure, aortic pressure, okay. This kind of diagram is also plotted in clinical medicine also. That's why we are plotting the left ventricular pressure volume curve, pressure time curve rather than right ventricle, because that has more clinical significance, right? So now I am trying to understand that during isovolemic contraction, okay, so first phase is here, the isovolemic contraction. During isovolemic contraction, what will happen to ventricular pressure, what will happen to aortic pressure, right? So isovolemic contraction means, okay, beginning of isovolemic contraction, all of you please note down, the beginning of isovolemic contraction means this is the end of diastole and beginning of systole. So end of diastole means, if I ask you what will be the pressure in the ventricular cavity, end diastolic pressure in the left ventricle, could you answer? End diastolic pressure. So if I ask you that what is the pressure at this point, this is nothing but end diastolic pressure. If I ask you how much that is I told you already 5 to 12 or 4 to 12 millimeter of mercury. So this is around 4 millimeter of mercury, suppose, right? Okay. So this is the pressure at the end of diastole. This is the pressure at the beginning of isovolemic contraction. Now I am asking you, what is the pressure at the level of arch of aorta at the beginning of systole? That will be the diastolic pressure, and that will be 80 millimeter of mercury. That's why you look at, I have plotted the aortic pressure to a higher point, that is the high pressure, 80 millimeter of mercury, and ventricular pressure is 4. Now, whenever the ventricle will contract during this isovolemic contraction, the ventricular pressure will gradually rise like this, Ultimately, what is the target? Ultimate target is that during this isovolemic contraction, ventricular pressure has to be more than aortic pressure, then and then only there will be opening up of the semilunar valve, we have discussed earlier. So that's why I was talking about that cardiac cycle phases you have to understand first, okay, to look at the pressure volume changes, okay. So during this isovolemic contraction, the ventricular pressure is rapidly rising. During this rapid rise of ventricular pressure, aortic pressure will not changes much, so aortic pressure will remain same. But you look at this point, which point? Here, okay, the point on the second line. At this point, due to contraction of the ventricle, the ventricular pressure is going above aortic pressure. Ventricular pressure is increasing more than aortic pressure. So what is going to happen? All of you will be easily answer here that one event is going to happen here, and that is nothing but opening of aortic valves, right? So this is the point where aortic valve will open up. Now whenever the aortic valve is opening up, what will happen? The ventricle will eject blood to the arch of aorta. So ventricular pressure will also go on increasing during this phase. Why? Because ventricle is still contracting, na? So ventricular pressure is still increasing, right? And ventricle is ejecting blood to the arch of aorta. So what will happen to the aortic pressure? Aortic pressure will also rise proportionally. So aortic pressure will also rise during this phase. But look at this two curve. Aortic pressure is below the ventricular pressure. That's why the blood is going out, right? So aortic pressure and ventricular pressure both are rising proportionally, but aortic pressure is still little lower than that of the ventricular pressure. That is during the early stage of ejection. Now, whenever the ventricle is contracting more and more, ejection is going on. Now the ventricular pressure will start falling. So now the ventricular pressure curve will start going down like this. Now the ventricular pressure is start falling, right? What will happen to the aortic pressure? Aortic pressure will also fall, but look at the curve here. aortic pressure is also falling proportionally, but now the aortic pressure is little above the ventricular pressure. Oh my god. So this is the phase of ejection. Aortic pressure is more than ventricular pressure, but still the ejection is going on. How that is possible? Aortic pressure is more than ventricular pressure, so blood should fall back. But during the later half of ejection, particularly during the slow ejection phase, the aortic pressure is becoming more than that of the ventricular pressure, but still the ejection is going on. This is due to momentum of the flowing blood. Getting my point? You know the momentum meanings. You have pushed the volume of blood, and that blood is going towards the aorta with a momentum. Okay, although the ventricular pressure is lower than that of the aortic pressure, but still due to the momentum, the blood is still going towards the arch of aorta. And that's why, look at these two curves. Okay, both the curves are going on proportionally, but during the rapid ejection phase, ventricular pressure is more than aortic pressure. During slow ejection phase, aortic pressure is little more than ventricular pressure, but still the ejection is going on due to momentum of flowing blood. But this momentum will not continue for long. We all know that. So what will happen? Ultimately, one point will reach where this momentum of the flowing blood is reduced. So this is the point. Now the ventricular pressure is very, very lower than that of the aortic pressure, and momentum of the blood is lost. So now what is going to happen? Now the blood will try to fall back from the arch of aorta towards the ventricular cavity, and we all know that that will be prevented by immediate closure of this aortic valve. So this is the point where closure of aortic valve is going to happen. Getting my point? So this is the second point. Again, you have to remember, very, very important, that aortic valve is going to close when the momentum of the flowing blood is finished and the ventricular pressure is lower than aortic pressure. Now what is going to happen? Whenever the aortic valve is closed, that means semilunar valve is closed, now there is starting of isovolemic relaxation. So isovolemic relaxation, what happens to the ventricle during isovolemic relaxation? Ventricle will relax more and more, due to which the ventricular pressure will fall to near equal to 0 millimeter of mercury. So I will plot that curve. So now the ventricular pressure will fall, rapid falling of pressure. And if you look at this fall of pressure will continue to a lowest level of ventricular pressure, that is near equal to 0 millimeter mercury. If you plot this now, so this point is even lower than that of the starting point of 4 millimeter of mercury, because this pressure is near equal to 0 millimeter of mercury pressure. And I told you that this is the point where the filling of ventricle will start once again. This is the point which is the point where ventricular pressure is lowest. And what event is going to happen? Here there will be opening of the mitral valve or tricuspid valve, and whenever the mitral valve and tricuspid valve is opening, again the ventricular filling will start and the ventricular pressure will start rising once again, right? So this is the part where the ventricular pressure is start rising once again. This is what phase? This is nothing but the filling of ventricular phase. This is nothing but filling phase of ventricle, passive filling followed by active filling. Getting my point? The ventricular pressure will start rising once again. So that's why I told you earlier, if you look at the ventricular pressure curve, it will rapidly go upward, and then it will slowly rapidly come back, and then slowly it will rise like this. This is the typical ventricular pressure curve, right? Now you look at the aortic pressure curve. You follow the green line. So you have seen that during the closure of the aortic valve, the aortic pressure, what will happen after this point? The aortic pressure will rise a little bit, and then the aortic pressure will be stabilized at diastolic pressure. So this is nothing but diastolic pressure. The aortic pressure will be stabilizing, but before stabilizing, what I told, there is a little rise of aortic pressure. This is again very, very important. So now I am asking you, please look at the aortic curve, that is the green color line. Okay, green color line. So if you follow this, there is flattening of pressure, no rise of pressure. Suddenly there is rise of pressure during opening of semilunar valve. Then there is dropping of pressure. Whenever there is closure of the semilunar valve, again there is a little rise, and then there is stabilization of the pressure. This is typical aortic pressure curve. Very, very important. Look at here. This is rising, then decreasing, a notch, then a little rise, and then stabilization. This is typical of aortic pressure. So if I only draw this, okay, only draw this aortic pressure, okay. So where I will draw, okay, I will draw here. Now I am drawing only the aortic pressure, very very important to understand, right? You are getting a curve like this, okay. So this is aortic pressure curve, aortic pressure curve. Aortic pressure curve is typically recorded at the level of carotid artery by placing one carotid pressure transducer. So if I place one carotid pressure transducer, okay, then you are going to record this kind of curve. This is pressure changes at the level of carotid artery, which is nothing but reflection of the aortic pressure changes. If you record the pressure changes from any peripheral artery like radial artery, you are also going to get similar kind of curve, but in a distorted fashion. The peaks and the pressure will be a little different, but the shape will be maintained. But if you look at the level of capillaries, this kind of peaks are very faint, right? But what I am saying, that if you record this pressure changes at the level of carotid artery, you are finding out that there is increase of pressure, rapid increase of pressure, and then the aortic pressure or carotid pressure is reaching to a peak point. This peak point is nothing but our systolic blood pressure point. The maximum pressure during ejection of the blood, okay, at the level of aorta is nothing but systolic blood pressure, and I told you this portion, the pressure where it is the aortic pressure is stabilizing, this is nothing but my diastolic blood pressure, okay, right, lowest pressure point at the level of arch of aorta. But when the blood is ejected at the level of arch of aorta, ejection is starting from which point? This is the point where the ejection is starting. So this is the point where ejection is starting due to opening up of the aortic valve. There is rapid rise of aortic pressure. This rising phase of aortic pressure is known as percussion wave. This is known as percussion wave in aortic pressure curve. Very very important for MCQ. Percussion, P-E-R-C-U-S-S-I-O-N, percussion wave. Then after the blood is ejected, now the aortic pressure is start falling. So now the aortic pressure is start falling, right? During this falling phase also, you may get a little elevated point. You may get a little elevated point. Sometimes this wave is known as the tidal wave. Okay, sometimes this is known as the tidal wave in the aortic pressure curve or carotid pressure curve. What is the meaning of this? Meaning is this: suppose this is left ventricle and this is arch of aorta. Whenever you are ejecting blood at the level of this arch of aorta, right, what will happen? Arch of aorta contain huge amount of elastic tissue. So there will be expansion of this arch of aorta. Along with that, the blood which is ejected, that will be reflected back from this aortic valve, little reflected back. So due to this reflection back, reflected waves, what will happen? The aortic pressure may rise a little bit. This is known as reflective wave, and this reflective wave is nothing but the tidal wave. So if I ask you that what is the cause of this tidal wave generation, this is nothing but known as reflective wave from aortic valve, right? Reflective wave, that is tidal wave. So what is the cause of this percussion wave? All of you know the percussion wave is nothing but due to ejection of blood in the arch of aorta. Now we know this thing. Okay. Now we will look at this diagram once again. Okay. So you have ejected blood, the arch of aorta is expanded. Now your ejection has been reduced. So during the slow ejection phase, the ejection is gradually reducing. So what will happen? The aortic pressure will be higher than that of the ventricular pressure. Whenever the aortic blood is trying to come back towards the ventricular cavity, we have already seen that this will lead to immediate closure of this aortic valve or semilunar valve. After the closure of this semilunar valve, what is going to happen? Okay, so the aortic pressure was falling. Suddenly the semilunar valve is closed. Whenever there is closure of the semilunar valves, it will lead to production of this notch. So this notch, which is due to closure of aortic valve is known as dicrotic notch. Dicrotic notch. Getting my point? So dicrotic notch is nothing but it is the closer point of the semilunar valve or closer point of the aortic valve, right? So pressure in the arch of aorta is falling, suddenly there is closure of the semilunar valve and that is producing a notch. But after the closure of the semilunar valve, the already expanded arch of aorta will return back towards the baseline. So if I just remove this, okay, I told you that during ejection the arch of aorta is expanded. Now the arch of aorta will return back towards the original position. This is elastic recoiling, right? Whenever there is elastic recoiling, the semilunar valve is already closed. So there will be some generation of pressure at the level of this arch of aorta. This will increase aortic pressure, and that increased aortic pressure is detected by this aortic pressure curve, and that is here. So this rise of pressure after this notch or after this closure of the aortic valve, this is known as dicrotic wave. This is known as dicrotic wave, and this dicrotic wave is due to elastic recoiling of aorta. Okay, recoiling of aorta and major vessels, right? And after this elastic recoiling is done, now the pressure in the arch of aorta will gradually fall to the diastolic blood pressure line, right? So now I hope all of you get to know different waves in the arch of aorta pressure or the carotid artery pressure. So basically bottom line is that the aortic pressure curve or the carotid pressure curve looks like this. Okay, mainly it is the dicrotic notch followed by a dicrotic wave, right? So this is dicrotic notch. Sometimes you may get a reflective wave here, that is known as the tidal wave, right? And I told you this rising phase of the aortic pressure curve, this is known as the P wave, then this is tidal wave or T wave, and this is the dicrotic wave or D wave, right? Sometimes this percussion wave is also known as the anacrotic limb. This is known as the anacrotic limb of the aortic pressure curve, and this limb is known as the dicrotic limb of the aortic pressure curve. This is known as the dicrotic limb of the aortic pressure curve because the dicrotic notch is there. Getting my point? So I told you that this wave, this is due to changes in the pressure at the level of arch of aorta, which can be easily detected by carotid pressure transducer. So basically this is carotid pressure pulse. Okay, by identifying or by recording this pressure pulse from the arch of aorta or carotid artery, you can also diagnose certain abnormal pulsation, and that we are going to discuss here. So look at, this is the diagram I have taken from Harrison, the same diagram that we have discussed earlier. Okay, that is the aortic pressure curve or the carotid pressure curve. So you can find out here, this is the P wave or the percussion wave, right? Okay, before that S1 has already been created, right? Okay, and then this is the dicrotic notch pointed out here. This is dicrotic notch. So I can understand that from this onset of this wave up to this dicrotic notch, this is nothing but phase of systole, and after the dicrotic notch, the remaining portion is nothing but the diastole during the diastole. I hope this is clear, because closure of the semilunar valve means after that, that is diastole, right? So this during this diastole, the dicrotic wave is created. Okay, and this percussion wave and tidal wave, they are part of the systolic wave. This is a normal pulse which is recorded from carotid artery region, right? Now, if you are getting the slow upstroke of this P wave, so I can understand that if the ejection is not proper, during ejection if there is certain kind of problem, right? So what is going to happen? The ejection is problem means what is going to happen? There will be slow upstroke of the percussion wave, and that is known as the anacrotic pulse. So anacrotic pulse, right? It is nothing but slow upstroke of the P wave. So you can get here that P wave is not smooth. Okay, the P wave is not smooth, slow upstroke, and obviously the peak of this P wave is also not reaching to the normal level, and that typically happen in case of aortic stenosis. Because this is affecting the anacrotic limb of the pulse is also known as anacrotic pulse. Now, if you are getting two peak, one is during this ejection phase, that is due to the P wave or the percussion wave, and another prominent peak which is due to the dicrotic wave, which is during diastole. Okay, so this is happening during diastole, and another peak, this is during systole. So this kind of pulse, when you are getting one peak during systole, one peak during diastole, which is appearing after dicrotic notch, that kind of pulse is known as dicrotic pulse, which is typically seen in case of low volume, low cardiac output condition. Low cardiac output condition mein this you are going to get this kind of pulse. But if you are going to get two peaks and both the peaks are appearing during systole, right? So that kind of pulse will be known as bispherians pulse. Bispherians pulse. What do you mean by that? You are getting one peak here due to the P wave and another very prominent peak that is due to the T wave. So I can understand that P wave is also prominent, tidal wave is also prominent. Tidal wave also prominent means your reflective wave from the arch of aorta is becoming very prominent, and that is known as the bispherians pulse. But both the peak you are getting during the phase of systole. So bispherians pulse you can get during the severe aortic regurgitation also, or you can get during hypertrophic obstructive cardiomyopathy also, HOCM. So you can get during severe AR or HOCM patient bispherians pulse. One peak is due to P wave, one peak is due to T wave or tidal wave. That is